Hello, this is Dr. Richard Senelick. I'm a neurologist who specializes in neurorehabilitation and the editor-in-chief of Encompass Health Press. This presentation is going to cover the issue, or question really, of where should rehabilitation take place. In other words, when someone has had an injury or a stroke, is in an acute care hospital, or could be someplace else, could even be at home, how do we make the decision as to where that patient should go for rehabilitation? What's the science behind it and the medical literature behind it? So we're going to look first at three basic questions. These are questions that we have asked over the years, and some are answered in the medical literature, and some we're going to answer today. The first, is rehabilitation effective in improving a patient's functional abilities? And I think the literature fully agrees on that, and the answer is a resounding yes. Is rehabilitation cost effective? I don't think there's any question about it that if we can get a patient home, reduce the amount of resources that they utilize, that it's definitely cost effective. The question over the last, particularly I would say, decade, has been where should rehabilitation take place? The main question has been, should a patient go to an inpatient rehabilitation hospital, or should they go to a skilled nursing facility or nursing home? Over the last, 10, 15 years, even probably longer than that, skilled nursing facilities have changed their names and are rehabilitation centers and are performing rehabilitation to a lesser extent within their facility. And the question one has to ask, is this as effective? Are patients having as good outcomes? And is this then a cost-effective way of delivering rehabilitation services? So first we're going to look a little bit at research, and we'll look at animal studies very briefly, and then look at some clinical studies. Whenever I lecture, I'd like people to remember three key things. And the three key things that have to do with neural repair, or repair particularly of the nervous system after brain injury, stroke, spinal cord injury, are dose, function, and motivation. So the dose or number of repetitions of the therapy is important. How much therapy is the patient getting? There is a whole lecture on what is the right dose of rehabilitation. And inpatient rehabilitation facilities supply a minimum of 3 hours of therapy per day. And the medical literature supports that this makes a significant difference in functional outcome as opposed to getting lesser amounts or fewer repetitions. It's kind of like if I'm going to practice a musical instrument. And we'll talk about that in a bit. The task needs to be a functional task. So if I'm going to improve at something, I need to be doing that task. And then it needs to take place in a highly motivated environment. So the three keys are that we need to have an adequate dose of therapy, performing functional tasks, and in a highly motivated or enriched environment. We could do a whole lecture, and indeed there is one that I've done that you can listen to on neuroplasticity or neural repair, why rehabilitation works. But neuroplasticity is the ability of the central nervous system to adapt to injuries or environmental requirements. And so that's very fancy words for how does the brain repair itself and recover from a stroke or traumatic brain injury. So rehabilitation, basically like going to school, can be the most difficult school, and many patients say rehabilitation is the most difficult thing they've ever done in their life, but you're basically learning things that you knew in the past, so relearning, or learning new things. So rehabilitation or learning, this dose of a highly motivated environment of a functional task, drives recovery by enhancing or promoting the connections that existed in the brain to try and put together that neural network and restore function. The brain is kind of at a delicate spot, or the nervous system is. So after a stroke, in that window of time, particularly that first 30 days, where the patient may have lost an intermediate number of connections, they still have connections and neurons and things in the brain that can be reconnected. There's an opportunity. That picture on the right is kind of supposed to be clever, and it's a window of opportunity. And indeed, there is a window of opportunity or critical state when these connections can either be permanently lost, or we can try and put them back together or get other parts of the brain to take over that function. And that's where rehabilitation really fits in and takes over, as opposed to doing nothing. This was one of the groundbreaking studies done by Randy Nudo at Kansas. And I think it's back in about 1997. And Dr. Nudo took 3 groups of monkeys, and he gave them all the same stroke. So I think we can go on to here. And he gave them all the same stroke, where you can go in and tie off an artery inside the brain on the surface, and they all got a stroke involving the upper extremity. So let's say, just for our sake, that there were 10 monkeys in each group. So the first group had the same stroke as the second group and the third group. They all had a paralyzed upper extremity, and they all got the same cage and the same food. So it's the same environment, and we're merely looking at what type of rehabilitation or exercise program did they get. So the first group didn't get any type of rehabilitation at all. They got fed, they got the same cage. And what we're tracking is 2 things. We're looking at how much better did the monkey get as far as improvement in function of that upper extremity. And then Dr. Nudo also stimulated in the brain, the area of the stroke, to see, did areas next to the stroke take over function and help out. And I'll show you a picture of that. Second group had range of motion exercises only. And we didn't want them to get tight, so you could envision maybe a group of patients just sitting in a circle, raising their arms, having somebody raise the arm for them, and so just not doing functional tasks, but range of motion exercises. And the third group had full rehabilitation. So they had the same cage, same food, but now they were doing functional tasks driven predominantly by activities of daily living. And you're saying, well, wait a minute, how did you do this? Or how did he do this in monkeys or in primates? So the first 2 groups, remember, one getting nothing and the other getting just range of motion exercises. And lo and behold, when he looked at how much better did they get, there was some spontaneous or natural recovery, but it was about the same. The monkeys that got nothing and the monkeys that just got range of motion exercises. And when he went ahead, let me see if this pointer works. We'll get it over here. And he stimulated in this area to see what was going on in the brain. The strokes increased in size somewhat, and the areas next to the stroke really didn't help out. There really wasn't any evidence of neural plasticity or neural repair. So this is how you do rehabilitation in a monkey, and it's very similar to constraint-induced motor therapy or force use therapy that we do in humans. So the monkey had a little vest or jacket that constrained the unaffected arms, so he couldn't use it. And we're going to have a highly motivated task, an activity of daily living, which is food. So we got eye-hand coordination driven by the desire to eat. And the first thing we're going to do is have a larger well here, so the monkey has to use a forced grasp. So think about your children or your grandchildren as they're learning to eat, and they start to grab things. They don't have fine coordinated movements, and they may grab a bunch of spaghetti. Or when my grandchildren were little, I had carried jelly beans, and they would take their whole hand and try and grab a whole bunch of jelly beans. Once the monkey becomes proficient at this, we make the well smaller And now as the well gets smaller and smaller, the monkey is forced to use fine coordinated movements. So we're forcing functional tasks until finally this is like a pincer single pellet, single jelly bean that has to be picked up with maybe just a thumb and the index finger. Remember, the things that separate us from the primates isn't opposable thumb, but they're still able to grasp an individual pellet. And what Dr. Nudo found was that those monkeys that got full rehabilitation were doing many doses of a functional task improved significantly more than those monkeys that just got range of motion exercises or nothing. And the other thing is, if we go over here to the right side again with my pointer, when he stimulated the part of the brain with the stroke, he found that it had not increased in size as much as the other strokes, but also the area adjacent to it for shoulder movement had now taken over the function of hand movement. We were able to encourage neuroplasticity or other parts of the brain to now take over that function. The other issue is that of enriched environments. Remember we said, so it's dose, the amount of therapy that the patient, or in Dr. Nudo's experiment, the monkeys got, and they performed a functional task, and now does the environment in which care takes place make a difference? This is again a study about the same time as Dr. Nudo's initial study, and these are mice raised in an enriched environment with all of the toys that, I guess a mouse would ever want, and that they can play with. And then what they compared this to, the authors, are mice raised in a standard laboratory environment. On the left is a glass cage, and some graduate student or somebody has responsibility to go in and clean out that cage. And on the side it may say Senelick, experiment number 1422, and the date that they were last fed. And what we were looking at in this study was the part of the brain that has stem cells that's capable of making new neurons, and that's the more primitive area, or the hippocampus, has to do with memory. And seeing were mice that were raised in an environment, an enriched environment, with all the toys and more going on, what happened there? And if we look on the right, we can see that those mice had more neurons, more brain cells grow in that area than the mice raised in the control environment. And there are many studies now in both animals and in humans about the benefits of an enriched environment. And if we think about a rehabilitation hospital versus a nursing home, the difference is stark, and that would clearly be the difference between a standard environment and an enriched environment. So if we look at the difference between inpatient rehabilitation hospitals and skilled nursing facilities, patients are coming to an inpatient rehabilitation hospital sooner, sicker than we've ever seen them in my long career. There's been this dramatic change in how sick people are when they come. Let me move back to the previous slide. There we go. So that having a physician, internal medicine, primary care, rehabilitation doctor, seeing the patient at least 5-7 times a week makes all the difference in the world. In a skilled nursing facility, a physician only has to come by every 30 days. In a rehabilitation unit, maybe it'd be once a week, maybe twice a week. An extended care or medium level practitioner, physician assistant, nurse practitioner might come by. So the statement that I hear frequently is, well, I think this patient's too sick to go to rehab. I'm going to send them to a skilled nursing facility. Just doesn't make a lot of sense to me, because if anything, these patients need more medical care, and as you'll see, more nursing oversight. So you must have a multidisciplinary team in an inpatient rehab hospital that meets and has team conference, not required in a SNF. 24-hour-a-day registered nurses, usually these are CRRNs, certified rehabilitation registered nurses, whereas in a skilled nursing facility, you only have to have 8 consecutive hours on any given day. So think about how sick our patients are that are coming to us today, and that you don't have an RN there all the time, particularly nurses that understand rehabilitation. Same thing with nursing hours per patient day, the idea of specialty, rehabilitation nursing. And then that in an inpatient rehabilitation hospital, you're going to get an adequate dose of at least 3 hours a day of therapy, where there really is no minimum requirement in a skilled nursing facility. And many facilities are just giving 30 minutes, some an hour and a half, but not supplying this, remember, adequate dose of a functional task in an enriched or highly motivated environment. So what does evidence-based medicine tell us about stroke and other diagnoses? We'll predominantly have the most data on stroke. So what is evidence-based medicine? And that's what we really want to look at, not just sort of, well, let me tell you, I had a patient go to such and such place and they did fine, so I'm sure that that's going to be okay. Well, it is the conscientious, explicit, and judicious use, a lot of fancy words, for the current best evidence in making decisions about the care of individual patients. So we know that for strep throat, we know what the dose is of penicillin or amoxicillin. For hypertension, we know what the standard of care is. For managing cholesterol, we have guidelines and standards. And as you're going to see, we now have guidelines and standards for rehabilitation. We have evidence-based practices telling us where should a patient go for their rehabilitation stay and what is the proper dose and care of a patient. Let's take stroke survivors. There's 795,000 strokes a year. There's 10 to 20% that recover pretty quickly and may get even to full independence within 2 weeks. Now, a lot of times we look at those patients and people think, well, they're a great rehab candidate, and no question, we'll send them for rehabilitation. And in fact, they're doing so well that they might do well either on their own or with home health, outpatient therapy. There's 10 to 20% that are in the severe residual deficits, and those people still need rehabilitation. I'm going to cover that just very briefly in this lecture, although I do have a complete lecture that's called No Stroke Left Behind, what our approach should be to low-level strokes, because we tend to deny these patients rehabilitation and send them either to a skilled nursing facility or home, and you can pick that up and this information in this other lecture. But if there's 60 to 80% in this middle group, this then is a group that we can all agree, these folks need rehabilitation, and this is a large number. So if we take 800,000 stroke patients, it's at least 500,000 patients a year, and we know from statistics that the number going for rehabilitation is dramatically lower than that. So we create what's called a glass ceiling effect. Glass ceiling effect is that if I don't do something for you, if I, let's say, don't send one of my grandchildren to school, chances are they're not going to do as well as somebody that went to school. I take a guitar lesson every week and practice. If I don't practice and get any instruction, unless I'm, really a prodigy, chances are I'm not going to do as well as the person who is taking lessons. Well, the same thing is true here. If stroke survivors are denied access to inpatient rehab hospitals, they may never reach their full potential. That we're creating, as pretty as this is, we're creating a glass ceiling for them. And it can become a self-fulfilling prophecy. I'll have someone say, the patient, I think they're too low level. I don't think that they can go for rehabilitation. I'm not going to send them for rehabilitation. And then you see the person a couple months later, and they say, well, they really didn't get better, so see, my decision was a correct one. Well, it's a self-fulfilling prophecy. If you don't send someone for rehabilitation and they don't do as well, they didn't get the right dose of a functional task in an enriched environment in order to get better. Just quickly, I just want to touch on it here, and then I have a whole lecture on it. what do we do with these most severely affected that need rehabilitation? One of the things is if we want to try and get them home, and what the literature will show us is that patients that are considered having a severe stroke, low level, for the most part, many people wouldn't consider them a candidate for rehabilitation, that over 60% of these people can go back into community living and back home after rehabilitation. An important part of that is caregiver training, getting the education, and inpatient rehabilitation hospitals are set up to do that. One of the highest correlations of self-esteem in a human being is continence, bladder and bowel function, and one of the highest determinants of whether someone goes home after a stroke is continence. So inpatient rehab hospitals have active bladder and bowel programs. It always amazes me that I walk in any rehabilitation hospital, and unless someone's just had an accident, they don't smell because they have bladder and bowel programs and retraining programs, as opposed to skilled nursing facilities, which are not going to have these type of active programs. Proper seating and splinting is critical. If you go to a skilled nursing facility, you're not going to get a customized wheelchair, where in an inpatient rehabilitation hospital, if you have a hemiparesis, paralyzed on one side of the body, well, you need a hemichair that's properly fitted for your size, has a trough to support your arm, has brake extensions that allow you one-handed to control the brakes and propel the wheelchair with one hand, so that there's a whole process of seating and splinting to prevent contractures that isn't going to take place in a skilled nursing facility. Feeding and then transfer techniques. Can Mrs. Smith transfer her husband so she can take him home? And this type of patient education. Just the ability to transfer can be the difference between making it home and not making it home. So a lot of these basic activities that we're going to cover in much greater detail in our severe stroke, low-level stroke patients. So here was a study about, again, at the same time, we're starting to see all this activity a little over 20 years ago looking at this. And this is about the same time as Randy Nudo's study and the study on enriched environments. And this was a question paper that looked at large numbers of patients. I think it was 800 patients. I think we'll see that on the next slide. Is there a difference of patients that have regular Medicare, fee-for-service, and those that have managed care, what's called Advantage Medicare today, and are more likely to go to a skilled nursing facility? The study wasn't surprising that patients that had fee-for-service, regular Medicare, were more likely to go to a rehabilitation hospital, and patients that had managed care were more likely to be sent to a skilled nursing facility. We are starting to see some movement in this area, in that we believe that Advantage Care and managed care companies are starting to see the advantage of going to an inpatient rehabilitation hospital. You're much less likely to be readmitted back to an acute care hospital. It's about half. I think overall it's 9% of patients that go to a rehabilitation hospital will require transfer back to acute care, and it's 19% for skilled nursing facilities. And then if you look at 30 and 90-day readmission rates, you have similar type of issues where much less likely if you go to a rehabilitation hospital. But in this study, patients going to a rehab hospital, as opposed to a skilled nursing facility, were 3 times more likely to go home. That's an astounding statistic. 3 times more likely to sleep in their own bed, have their own pillow. I always find if I travel, and you can stay in a really nice hotel, but there's nothing like getting home and having your own pillow and sleeping in your own bed, and your family can come visit, and they're your things. So this isn't just a little bit more, but 3 times more likely. That's a big number. This was another paper, and this is Pam Duncan, a physical therapist who has done lots of research studies on outcomes of stroke patients and all kinds of rehabilitation patients. And she looked at the difference in going to an inpatient rehab hospital versus going to a skilled nursing facility. And what she found was sending patients to a skilled nursing facility was cost ineffective over the long term and actually detrimental to patient recovery. And I think that's what everybody's starting to see now as the literature confirms it, and that we get very interested in these readmission rates and what happens to the patient after they've had rehabilitation, and finding out that it's much more cost effective to spend a little more up front, send the patient for inpatient rehabilitation, and avoid those readmissions. This was a study, and there have been others that I cover in the low-level stroke lecture, that looked at what if we supply the same kind of rehabilitation that we give everybody else to patients, and this is when we were doing FIM. We just switched from FIM, functional measures, to functional outcome measures, to FOAM. So it's FIM, functional independence measures, have now become functional outcome measures, FIM to FOAM. But Dr. Schmidt and Dombovy and colleagues looked at patients with low FIM scores. So these were patients with severe strokes. They used normal length of stays for rehabilitation. And this is back in 1999. And I'm going to bring you forward, but I want you to see what this has really been going on for 20 years. And that stroke patients who were in a formal rehabilitation program had better outcomes than patients who were in nursing homes, and over 63% were discharged home. And for low-level stroke patients, that's a big number. And then 20 years later, so now I'm going to bring you up quickly to 2016. And this is when the American Heart, the American Stroke Association came forward with guidelines, and it's a guideline for adult stroke rehabilitation and recovery. In other words, what constitutes appropriate rehabilitation for a patient that's had a stroke? And the American Heart and the American Stroke Association release all kinds of guidelines. What's the proper guideline for hypertension, treatment of blood pressure, for cholesterol, treating an acute heart attack. They have guidelines for the treatment of an acute stroke, clot busters, a thrombectomy, or going in and getting the clot. And now they've come out with this very nice paper, and it's a long paper. I'm only going to give you the highlights on what should we do when a patient's had a stroke. This has been endorsed by the American Academy of Physical Medicine and Rehabilitation, the American Society of Neurorehabilitation, the American Academy of Neurology. And you can see these are the major organizations in the American Congress of Rehabilitation Medicine. This is something that all of the major organizations and physicians and healthcare professionals who treat patients with stroke have endorsed this guideline. And the bottom line from 2016 is that if possible, people who've had a stroke should be sent directly to inpatient rehabilitation after their hospital discharge. This would be instead of a skilled nursing facility or nursing home, and this was according to the new guideline of the American Heart and the American Stroke Association. And I think there's a reason that they specifically say sent directly. I didn't use it in here, the slide, but we have the statistics from 2017, or the most recent, from Medicare, and it shows what is the percentage of patients that get transferred from a skilled nursing facility to a rehabilitation hospital. So we're told, oh, I'm going to send them first to a skilled nursing facility, and then they'll send them to you when they're quotation marks ready, end of quotation marks, and it turns out it's less than 1%. So it just doesn't happen. And that's why it's important to look at this where it says sent directly. They have associated with this a list of frequently asked questions, and I just highlighted this one. There's details here of the differences between an inpatient rehabilitation hospital or facility and a skilled nursing facility, and again reiterating why it's important that they go, the difference in nursing, in therapy, in physician intervention. So now we have not just me or someone who works with us saying it, but this is the American Heart Association, American Stroke Association, endorsed by all of these other major associations. And we talked about evidence-based medicine. So they don't just come up with this idea that, well, we think this is the right thing to do. No, the high-level evidence is in favor of inpatient rehabilitation facilities, and it's the highest levels of evidence. And evidence, when we do research, is based on class 1 and class 2 and class 3, different levels of evidence. And this is the highest possible level of evidence which is supporting these conclusions. And again, their press release is whenever possible. The American Stroke Association strongly recommends that stroke patients be treated at an inpatient rehabilitation facility rather than a skilled nursing facility. While in an inpatient rehabilitation facility, a patient participates in at least 3 hours of rehabilitation a day from physical therapists, occupational therapists, and speech therapists. Nurses are continuously available, and doctors typically visit daily. An inpatient rehabilitation facility may be a freestanding facility or a separate unit of a hospital. So if we think back of when I was talking about what's involved in the 3 things of adequate dose of a functional task in enriched environment and gave you my breakdown of the difference, now you're seeing it reiterated in this guideline by American Heart and American Stroke Association. And what they say is if the hospital suggests sending your loved one to a skilled nursing facility, so now they're talking to patients and families. And for poor patients and families, this is a blind item. They're highly stressed. Their loved one has had a stroke. They don't really know the difference. We have to be an advocate for them, those of us in the healthcare professions. We're acting as a surrogate, really, for them and helping them make this decision. So now the American Heart Association is speaking to the patient who has had a stroke and to their family and says, if the hospital suggests sending your loved one to a skilled nursing facility after a stroke, advocate for the patient to go to an inpatient rehabilitation facility instead, unless there's a good reason not to, such as being medically unable to participate in rehab. And I can tell you from my experience and from the medical literature, that is a very small number of patients. So it's our responsibility. If you're a healthcare professional listening to this, then you are the surrogate, you are the advocate. And if someone says, well, we're just not going to cover this, we think they can go to a skilled nursing facility, then it's our responsibility to stand up and say, wait, but that isn't what evidence-based medicine says. Evidence-based medicine says that this patient should go to an inpatient rehabilitation facility. So given the complex needs of patients who require stroke rehabilitation, and remember when I said complex needs, I said it makes no sense if the patient has all these complex medical needs. Why would we say they're too complex for a facility where a doctor rounds all the time and nurses are specially trained and 24/7 are there, and send them to a skilled nursing facility that doesn't supply that? That's the complex needs. So complex needs of patients who require stroke rehabilitation and the conclusions of the new guidelines, it's clear that Encompass Health is well positioned to provide the coordinated and multidisciplinary care necessary for optimum outcomes with the best chance of functional recovery and discharge to the community, of getting home. And with that, reducing readmission, reducing 30-day, 90-day readmission during that time, and having a much better quality of life. But if that's not enough, that was 2016. Now I'm recording this near the end of 2019, and this article just came out in November in the Annals of Internal Medicine, one of our more prestigious journals for internists, one that you're going to find on all of their desks. And this was the Veterans Administration coming out and saying, we're going to come up with a clinical practice guideline for what should happen to stroke patients. And so this is the VA. The VA has 18.2 million veterans, and 9 million of these are served by the VA each year. So this is a very large number, and they're basically saying, not basically, they are saying, and I highlighted all this, you can read it for yourself, but we recommend using these guidelines as an adjunct to the American Heart Association, American Stroke Association guidelines. So the ones I just reviewed, now the VA, which is responsible for the care of over 18 million veterans, is saying patients who've had a stroke need to be seen by a multidisciplinary team that is basically provided in an inpatient rehabilitation facility. So now we have the American Heart Association, the American Stroke Association, we have the VA coming up and saying this, and just this month, this paper just came out, and it just came out December 4th, 2019. I'm recording this, and I have to look at my calendar or my watch, on the 14th of December in 2019 to give you a marker. So just 10 days ago, this came out in the Journal of the American Medical Association, another prestigious journal, and this study looked at over 66,000 stroke patients across the nation. These were Medicare beneficiaries, people who had Medicare and a stroke, and looking at the differences if they went to an inpatient rehabilitation facility or went to a skilled nursing facility. And it says those patients who went to an inpatient rehab facility demonstrated greater improvement in mobility and self-care compared with patients who received inpatient rehabilitation at a SNF. So now we have how many studies and how many guidelines supporting this, and so we can go back to 20 years ago when we said this, and now we have more and more evidence. So, I mean, the evidence is just absolutely clear-cut. So what else does evidence-based medicine tell us? One of the arguments I hear, not infrequently, is, well, maybe the patient's too old. Well, as I get older, I get really concerned about that. The fastest growing segment of our population is 85 years and older. So we're going to be taking care of a lot of older patients. If you work in a rehabilitation hospital, you know this, that the population of patients that you see is getting older and older. And we get excited, gee, treating a young stroke, and it's bad for that stroke patient, but sometimes our therapists say, let's start a young stroke program. And I say, well, that'd be great, except really who's having strokes is the older population. But there could be a tendency to say, well, maybe that patient's too old. So this was a study that just came out a few years ago that looked at rehabilitation outcomes in patients with stroke who are 85 years or older. And if you look at the right side of the slide, you can see 60% achieved community-based discharge. So that matches that study way back, again, almost 20 years ago, by Schmidt and Dombovi, where 62% of their patients made it back. And for this population of patients, that's a big number. If we said, we're going to send them to a skilled nursing facility, we're going to have this tiny number as opposed to this, 60% is a big number for this population of patients. The interesting thing is that multiple comorbidities, hypertension, diabetes, really didn't make a difference. And in the low-level stroke talk that I give in predicting outcome after stroke, only diabetes seemed to make any difference. And we're really good at managing that and controlling that. So a lot of times we'll say, the patient's got a lot of medical problems. I don't think they're a candidate for rehab. And as I've said earlier, but wait a minute, if they have a lot of medical problems, why would you send them to a skilled nursing facility where they're not going to be seen regularly by a physician or by a nurse? There's a cultural component. I'm in San Antonio, Texas, and a large Hispanic population is more likely to take care of their families and take them home. So where you live and the cultural component can make a difference. But if we look on the left side, the conclusion of the study, stroke patients who were in formal rehabilitation had better outcomes than those that were in a skilled nursing facility. So we have even one more study that confirms that. There's not a single study out there that really says, if you send patients to SNFs, they do just as well as going to an inpatient rehabilitation facility after a stroke. That literature doesn't exist. Kramer, and you can see how this all kind of really got moving in 1997. That was when Nudo published and some of those other papers. And Dr. Kramer has done a lot of research on what happens in skilled nursing facilities. And so he looked at skilled nursing facilities that claimed they were expert in doing rehabilitation. and he found that their outcomes weren't any better than regular skilled nursing facilities who didn't claim to have special rehabilitation expertise. And I did throw this data in here, snuck it in at the end. This is sort of hot off the press. The Medicare's always a few years behind in publishing their data, but this arrow at the bottom is what I wanted to show you, is that if a patient goes to an inpatient goes to a skilled nursing facility first, here's the blue arrow, that way over here, 1% maybe get subsequently admitted to a rehab hospital. That's only one patient in every 845 stroke patients. This is from claims data from Medicare. So this is nationwide. And you can see that more patients go to a SNF than that go to an inpatient rehabilitation facility. We don't know what's happening to these patients who go home. They're not getting home health. This is 12%. So we also have a large group of patients that aren't getting any type of rehabilitation care. And here's the readmission rate. And I think the next slide, this is acute care transfers. If you go to an inpatient rehabilitation facility, your chances during your stay of getting transferred back to acute care facility is about 9%. If you go to a SNF, 19%. And this isn't just our data. This is all aggregate data from the Centers of Medicare and CMS in their database for 2017, aggregating all of their data for comparing IRFs versus SNFs. Just a quick look at the 3-hour rule, and this was a study from 2013 that looked kind of at the floor, because what we're not sure of is where's the ceiling, how much rehabilitation do we need to do, but patients who receive at least 3 hours of daily rehabilitation therapy had significantly better functional gains and outcomes than those who received less than 3 hours of inpatient therapy. Inpatient rehab hospitals meet this standard. It's a requirement. Skilled facilities do not. So depending on where you are, what skilled nursing facility, you can get as little as 15, 30 minutes a day of therapy. Maybe you'll get an hour and a half, but you won't get 3 hours. And we know that the dose matters, and the dose of functional tasks in an enriched environment, and that's going to be an inpatient rehabilitation facility. So you get this higher level of care, just as to sort of sum it all up, of physician availability and visits to take care of sicker patients. You get the nursing hours with an RN 24/7. You have certified rehabilitation nurses, 3 hours of therapy a day, and the case management becomes really important. And when we talk about low-level stroke patients, you'll see I'll have a whole slide, different lecture, on family education. That whole component of getting ready to go home and the time that is spent so that you're prepared with the proper equipment. Just having the right wheelchair, properly seated, splinted, positioned, knowing what the resources are in the community. All of this takes place in an inpatient rehabilitation facility and not in a skilled nursing facility. We measure outcomes. I need to change that from film to foam, so it's functional outcome measures. Average length of stay is much shorter in a rehabilitation facility than it is in a SNF, with better outcomes, better patient satisfaction, and a better discharge to community. And one of the big things that I'll talk about when we do talk about low-level strokes is this whole issue of quality of life and what measures are for quality of life, and the difference of going to an inpatient rehabilitation facility versus a skilled nursing facility. This is what we call a spider graph, and it can look, whoa, this is, confusing, but these are generated for every one of our patients that goes to an inpatient rehabilitation facility, and the blue is where they start on admission, and this is functional outcome measures, and the purple is graduating to where they were at the time of discharge. And you can look at all the things that we measure: activities of daily living, bladder and bowel, all types of motor function. So we're honing in on every little aspect of the problem in an inpatient rehabilitation facility. So Kramer again, many of us think about that we'd rather, think of any other option than have to go to a nursing home. And Kramer really sums it up nicely. And he said, secondary to dying, nursing home placement for an older person who is in the community is the worst possible outcome. Knowing that transition, that they're never going to have their bed again, be in their house again. So we really need to make every effort by going to an inpatient rehabilitation facility to prevent this from happening. So to summarize, there's my fancy window of opportunity again. The intensity of rehabilitation drives success. Functional focus of rehab is crucial, that we have to be performing functional tasks. Having 6 people sit around in a circle doing range of motion exercises or throwing a beach ball isn't going to lead to neuroplasticity and neural repair. And that even modest functional improvement affects the future for people with severe impairments. So that list I gave you of things we do for patients with severe strokes, which is expanded, it fills 5 slides in the lecture on low-level stroke, makes all the difference. If I can just get Mr. Smith to transfer so his wife can get him from the wheelchair to the bed, he can go home. And so sometimes it's just modest functional improvement during that stay that'll be the difference of whether somebody makes it home or not. And clearly, I think we've established through guidelines, through studies, that rehab hospitals are superior to nursing homes for achieving greater gains in getting patients home. So George Eliot is really Mary Ann Evans, and she has another quote that I'd really like, is that it's never too late to be what you might have been. And this is a quote, and that is, there is only one failure in life possible, and that is not to be true to the best one knows. So hopefully everybody listening to this, and you're going to pass the message on to anybody you can get to listen to you, is that we must be patient advocates. We have to act as a surrogate for many families and patients who don't know what to do. And it's very clear from the medical literature, from the guidelines, what the proper thing is to do. And that's to send somebody to an inpatient rehabilitation hospital. And so if we fail to do what we know is best, then we've really failed. And with that, I will leave you and hope that you enjoyed this and that you will look for other lectures in our series of education from Encompass Health. Thank you very much.